Okay, so we are very grateful, very thankful for Dr. Felicity Sapp for presenting today. Dr. Felicity Sapp is a clinical director and owner of OCD and Anxiety Psychological Services in Calgary. She has extensive experience treating children, teens, and adults with OCD. She's a board member of the Scientific Advisory Committee of Anxiety Canada and a credentialed member of the Canadian Association of CBT. She provides training supervision to therapists as part of the Pediatric Behaviour Therapy Training Institute for the International OCD Foundation, and annually, since 2008, presents OCD and anxiety-related workshops in the USA and Canada. I therefore hand it over to you, Dr. Sapp.
Thank you very much, Julian. That's great. So I'm going to get ready to share my screen right now. Try to find the right one. There we go. Okay. All right. Well, thanks everyone for coming. I know it's quite bright and early, and I'm here to talk to you about exposure and response prevention treatment for pediatric OCD. And I want to talk today about what you and your patient need to know before we get started. And in my second webinar, I'll talk about more in depth on ERP. So these are my disclosures, and I don't believe there's any direct conflict of interest about anything that I'm talking about today. My learning objectives for you today is to be able to describe the core components of CBT treatment for pediatric OCD, to adapt CBT ERP treatment for children and teens with OCD, to be able to implement effective cognitive strategies when treating pediatric OCD, and to understand the important steps when first starting ERP treatment with children and teens. So the elements of treatment, we're going to talk today, like I mentioned earlier, just the first part of treatment, which is getting ready for treatment, including, and I'm going to talk first about these first 3 points, and then I'll get more in depth as we go through the webinar. Oops, sorry, just a second, there we go. And then I will talk about rewiring the brain and take it into the real world when we talk in my second webinar. So first of all, as a therapist, you really need to get your patient to buy into the treatment process. So first of all, what we want to do is get them sort of setting some goals. And while you're doing that, you want to talk about how the goal here is really to increase the youth's control and influence over OCD. You want to explain the risks and benefits of CBT treatment and talk a little bit about like, what would it be like if OCD wasn't in control of your life? And then based on that, help them set goals on what's important to them. Sorry, there we go. I also want to explain that OCD is treatable and that my goal is really to teach the patients how to be their own therapist. And to help curb expectations, I want them to understand that the goal of treatment is to learn to manage OCD and not cure OCD. Now, I know most of you work with children and teens, so I'm not going to go into depth around these developmental considerations, but I do think it's important to look at them in terms of the impact that it can have on treatment. So first of all, we want to kind of look at where they are in terms of their thinking abilities. So with children and teens, the amygdala is very prominent. With children, it's just there all the time. With teens, it's more when their emotions are strong. And with young children, you know, they're very reactive. They're going to be more concrete in their thinking. So we really want to make sure that when we're using the different types of materials, that they're very concrete and enjoy in using kind of child-friendly terms. And I'll talk about that a little bit more. Even though teens are more abstract in their thinking, one of the problems is because of their black and white thinking, you can, as a therapist, can often get caught up in trying to rationalize or arguing. They want to kind of talk back and rationalize with their fears, and that can also impact rapport. We want to look at how well they are, both children and teens are able to keep their attention. You know, with children, it's harder to keep the attention. With teens, it's more about wanting to keep the attention. So one of the things that's really important is with kids, I often intersperse a lot of activities. So we'll be drawing, we'll be writing, we'll be playing games, doing things that kind of get their attention. And then with teens, I'm going to try to use things that, like I use technology. We'll use their phones to write notes. We'll use YouTube. We'll use things that will keep their interest. And then both age groups, we want to look at, with younger kids, it's hard for them to kind of stick with that icky feeling. Whereas teens, again, it's that willingness. And so for both of them, we need to be able to help them be motivated to try to want to do this treatment. And so it's really important, especially with young ones, that we have a reward or incentive program in place. And it's going to be quite specific and for children, whereas for teens, it might be more that they reward themselves or the parent rewards them after they kind of do their tasks. And it might be that they're trying to earn something in the long term, whereas with kids, it's going to be much more specific, like a sticker program or a token program. With respect to children, parents are bringing them in, so they have more control. We want to, like I said earlier, we want to engage them into making it kind of fun. And so one of the things we want to do is kind of give OCD kind of a silly nickname and maybe draw a picture. Here's some quick pictures I can kind of show you. This was a little girl who had I guess it was more actually fear here around her little OCD monster is in there. This one, she called it Bad Piggy Pooch. And so there's some, and so we want to kind of make that concrete and have, make it fun for them a little bit, using child-friendly terms as well. Now with teens, they may not really want to be there, and often they're not, or they don't want to admit that they really need help. So you might have to use more kind of motivational interviewing skills, help them set goals based on their values. And often I'll say to them, hey, let's just try this as an experiment. Like, let's just try this out, kind of get your parents off your back and see how it goes. I'm going to use analogies and metaphors that the teens can relate to, depending on what their interests are. And important to understand, though, that the choice of being in treatment is really the teens. I'm not going to force them into treatment. And also, if they are having trouble getting into treatment, sometimes I might have to work with the parents first if they're accommodating behaviors at home to make it a little bit less easy so that the teens will come in. With respect to children, the therapist is going to have a much more directive role, and so is family, in the treatment process and also in coming up with what are we going to attack, what are the goals, what are the issues we want to look at. With teens, it's going to be more collaborative. We're going to really work together, and I'm going to really be getting them involved in what they want to address. And we're going to incorporate parents in treatment, but doing it with permission. So I'll often get them to sign a consent form to give me permission, even though legally I don't have to, but ethically, kind of that who is the patient idea, it's helpful. And in that, I kind of will also be very specific with the teen of what information they're willing to let me share and what information they're not. And why do we want to include teens? Well, sorry, not teens. Why do we want to include parents? Because it's really important for parents to understand that they don't need to rescue their teen, their youth, their child when they're in distress. And they also will learn from observing and watching and being part of ERP, and then they're able to generalize it into the home life. And also there's sometimes behaviors that parents need to change. Now, I'm not going to go into a lot of depth here on family involvement. Dr. Andrea Bliss will be talking about this in a later webinar, but there are some important considerations. First of all, we want to look at how much the family member is being tangled up in the rituals. We know that OCD does not affect just the child, it affects the whole family. And so we need to look at, are there behaviors that are being accommodated, and such as reassurance, and talk to them about what that's like and the education around it. And then finally, are there any family issues or conflicts outside of OCD that could be getting in the way of treatment, and they may need to be addressed? So when we're first getting into treatment, starting treatment, we really need to focus on kind of psychoeducation. And it is an opportunity to really allow the parents and the teens and the child to really understand what's happening in the brain and explain it in a way that will relate to the CBT-ERP treatment. I'm going to want to explain that circular nature of OCD. And like I showed you a picture of, like, see, OCD is kind of a bully and separate from them, to help really take away the blame and help and externalize OCD with the parents as well. I'm going to talk about the different treatment options, and if medication happens to be something that we're considering or using, then we want to talk about how, even though you're taking medication, the actions that you use, and which basically is doing rituals or not, is going to influence and will matter. And so use medical analogies. Now, I'm not going to talk a huge amount about the psychoeducation. I know that Dr. Arnold in the last webinar talked a little bit about that, but I do want to talk about how, what I want my patients to know, because OCD is kind of seen as this enemy, this bully, separate from them. And if we're going to learn how to take back control over this enemy, we need to know what makes it tick. So these are kind of the points I want them to understand. First of all, I want them to know that OCD is a neurobiological disorder. And so what that means is that it is the way that the brain is wired. And it's the way that the brain has become wired at this time. And this really takes away fault. It's not the parent's fault. It's not the child's fault. It's just the way the wiring of the brain has come together at this time. I want them to understand how obsessions and compulsions work together. And when I explain it, I often will use the analogy of a net. And I will say, so for example, I might see a doorknob, and an intrusive thought might come in my head, because we all get intrusive thoughts, that says, oh, there might be some germs on that doorknob. And because I don't have OCD, the mesh in my net is like this. And so when I have that weird, like that intrusive thought, it just off it goes. But for people who have OCD, the mesh in their net is like this. And so when that thought comes, it gets stuck in the net, and they can't, and it's kind of stuck there. And as long as it's stuck there, then they start to put some meaning to it. And they start to have thoughts like, oh my gosh, like if I touch that, I might get germs, and then I might get a bad disease. And what if I spread that to my mom? And what if she dies? And you can imagine that's a very anxiety-provoking thoughts. And so I don't like that feeling, and I've got to do something to feel better. So maybe they discover that, okay, well, if I wash my hands after touching the doorknob, whew, okay, that gave me some relief. Or maybe they talk in their head and say, no, that's not possible. Germs can't stay on doorknobs. And so, yeah, okay, I get some relief. So now what happens is the person has now done either something physically or mentally that now gives them that relief of anxiety. So the next time they have that scary thought or get in that situation, they're going to want to do that same behavior again and again. And then that talks about how we're getting caught in that OCD loop. I also want my patients to understand that really what's going on in the brain is that the amygdala is sending a false alarm. It's sending off a false message, and when it does that, it still triggers that fight or flight response. And so the body responds as if the danger is real. And this helps your patients understand that, yeah, what you're feeling is 100% real, and helps them kind of, that you understand what's going on. I'll often use with younger children the analogy of what happens, I sort of tell a story. What happens if a little boy or girl pulls a fire alarm at school without anybody knowing, little mischievous boy or girl? What's going to happen? Well, the fire trucks are going to come. Everyone's going to have to line up and go outside. And what they're doing is they're acting as if there is a fire because they don't know the difference. And so it's helping them understand that even though it's a false alarm, you still feel the anxiety. The other thing about OCD to understand is it is a fear-based disorder. And what that means is that there's always a fear underlying the obsessions, or underlying the obsessions. The other thing around OCD is that it feeds on doubt and guilt. And those are its two biggest pieces of ammunition against you. OCD also likes to go after what you hold the most dear. So what's important to the person? And finally, it will go after kind of normal developmental stages. You know, I think about puberty. I have lots of patients who come in where, you know, they're kind of in that stage of sexual curiosity, and OCD will take that and twist it around. So really, with respect to OCD, if we're going to be able to take back control over OCD, we need to learn to retrain the amygdala, to stop sending that false alarm, and to change the wiring in the brain. OCD wants people to be 100% sure that whatever they're afraid of isn't going to happen. And so what we really, and because there's no such thing as certainty, what we really need to do, and one of the biggest key components of ERP and fighting back OCD, is learning to live with uncertainty and learning to be able to get your patient to be able to take risks. There's sort of three main points that I would like people to understand. I sort of say my three take-home anxiety points. And the first one is that anxiety is normal and it's okay to feel it, and that we all do at challenging times in our life. You know, look at little Woodstock here. He's just kind of hanging out. He gets snowed on and, you know, Snoopy goes by. Well, that's what happens when you have no anxiety. With the older teens, I will want to show this graph. Showing them how the relationship between anxiety and performance, and that we need some anxiety. In fact, having some, we actually perform at our optimal. The second point that I want people to understand around anxiety is that, yeah, it doesn't feel good. It is uncomfortable. I mean, I've had patients who actually passed out in my office. I've had patients tell me about how they've called ambulances to their home because they think that they're having a heart attack or they're dying, or they go to ER. I've had people think they're going crazy. But the truth is, as uncomfortable and horrible and icky as that feeling is, it's actually not dangerous. And that's important for them to understand, that anxiety is uncomfortable, but it is not dangerous. And then the third point is I want them to understand the relationship between anxiety and time. Your body cannot stay in that highly sympathetically aroused state for a long period of time. It is too emotionally, mentally, physically tiring. And so eventually your body has to reset. So we know that over time, anxiety goes up and it comes down. Now, the problem with that, though, is it gets interrupted. When it gets too high, people want to do something to feel better. So, you know, someone with their OCD might do their ritual. Other people might get reassurance. Maybe they do some relaxation. They're going to do a behavior to feel better, to bring that anxiety down, and it works, right? The anxiety does come down, but it's just a temporary relief, because the next time that they have that same scary thought or get in that situation, they're going to want to do that same behavior again and again. And again, here we go. Here's that OCD loop, OCD trap that I talked about earlier. And you can kind of see here that, you know, on this half of the graph, I should use this. On this half of the graph, OCD is really in control. And what we want to do is get the child or the teen to this half of the graph where they can take back control over OCD. So when I'm explaining CBT to the child, teen, and the parents, I want them to understand that, you know what, reducing the anxiety is actually making OCD stronger, because anxiety is not the problem. The problem is the fear and the false alarm that's coming from the amygdala. And the problem is their response to that false alarm, the ritual. Now, I do want them to understand that I know OCD is scaring you so much that you believe you have to do these compulsions. But the reality is the choice is yours. And then I talk about, you know, what you've been doing right now to get rid of those obsessions. Has it worked? And often I get a no, or I get a short term. And so then I'm like, okay, well, let's just try something completely different. So what is the treatment for OCD? Well, as you heard previously from Dr. Arnold, medication and cognitive behavior therapy. I'm not going to go in depth into medication, obviously, because you already heard that for those of you who had tuned in. But I'm going to talk just briefly for those of you who didn't, and just a little bit of what the research shows. Basically, what we see is that CBT-ERP is effective. You know, there's been multiple reviews and meta-analyses over decades that has supported the use of CBT with children. And when we look at kind of some of the comparisons of medication and CBT, we really see that, basically CBT is effective, medication is effective, and the two together, the combination of the two is effective. And all of them are more effective than stress management or relaxation. The neat thing about this is it's not just seen in clinical settings. We also see this has generalized across community sites and countries. And finally, the durability of these gains are not just seen right at post-treatment, they actually can last up to several years. So I'm going to talk a little bit about what is CBT. Well, the cognitive aspect of CBT is teaching the youth to respond differently to the obsessions. The behavioral part is changing the actions that are used to decrease anxiety. And I really like how my colleague, Dr. Fred Penzel, puts this. He says, it is the behavioral part of CBT that gets you better. It is the cognitive part of CBT that keeps you better. So typically when I'm working with my clients, I'm going to go right into that behavioral part, which I will talk to you about later. But right now, I'm going to focus on the cognitive piece for you. So we're going to respond to the obsessions. How do we respond to the obsessions? Well, first of all, the main piece strategies that you want to do is helping teach your patient to recognize that the assumptions that are coming from, that are actually maintaining OCD are unhelpful. And these are assumptions like, because I have this thought, it means it's true. Or because I have this thought, it means I must want this thought. I must avoid feeling anxious. I can't handle uncertainty. And so I will challenge them around these types of thoughts by asking questions like, well, I've been thinking a lot about winning the lottery, but yeah, it just doesn't seem to happen. I can't make it happen by thinking about it. And then with my teens, I might say something like, okay, I want you right now to think about me having a heart attack. And then and did it happen? Well, no. So I'll challenge them a little bit around this. What I'm not doing is I don't want to try to use this as, we don't want to use cognitive strategies to try to prove that their obsessions are untrue. We don't want to argue with the content of the obsession. So I'm just going to show you this was how old was he? 11-year-old boy who OCD was scaring him and telling him that he was attracted to boys and that he might be gay. And so he called his OCD Tricky Trapper, and we sort of wrote like kind of the tricks and the truths, and after kind of challenging him a bit, these were things that he could kind of have to sort of remind himself of how Tricky Trapper tries to trick him. So for example, if you think about something, it means that it will happen. Well, how do you have some superpowers that I don't know about? Are you able to read the future and make the future happen? So we came back with another one is if you don't listen to me, and OCD his Tricky Trapper wanted him to figure it out, try to figure out if he's gay, then the icky feeling will not go away. And the truth is, well, eventually the icky feeling will go away if you don't listen to Tricky Trapper. But if we listen, then Tricky Trapper's going to bring back that worry. So with teens, I'm using kind of myths and facts. And this is just one of the things I do want to say real quickly is that this is an educational piece. I'm not wanting them to use these truths as a way to fight back an obsession, because then it's going to become a ritual. Okay, let's keep going. Some basic assumptions, and here's what we hear about all the time, right, of how to feel better. Well, let's replace a bad thought with a good one. Replace negative thoughts with positive ones. It's not enough to eliminate the negative. You must fill your mind with positive things. Well, when it comes to OCD, that is not helpful. It might help them feel better in the short term, but all it's going to do is cause that rebound effect, and the obsession is going to come back bigger and stronger. What about just, oh, I'm just going to ignore them. I ignore them. I'm just going to push them away and ignore them. Well, how do you ignore something that is in your head, right? We can't just forget about these thoughts. And the reality is if we try to push them away, they tend to come back. So we don't want to push away these thoughts. We want to just allow them to be there. What about just stop thinking about the bad thoughts? But when I do that, it's like, okay, I am not going to think about going crazy. Oh man, I've just thought about it. Or if I say to you, don't think about a pink elephant. I can't see any faces, but I suspect I would see some nods saying, yeah, I thought of a pink elephant. So we can't just stop thinking of bad thoughts. They're in our head, and so we have to just allow them to be there. What about challenging them? Let's be rational. Let's look at this irrational thought and talk back to it rationally. Well, if we try to argue or challenge the obsessions, all that OCD is going to do is bring back that doubt and guilt, and it's going to make it bigger and stronger. So what can we do? Well, really, the only way to be able to take back control from OCD is to accept the possibility that the fear or the obsession could be true. Again, this goes to this goes to the idea that we can't be certain of the future. And uncertainty is an uncomfortable position, but certainty is an absurd one. So let me give you some examples of how to talk back to OCD in an effective way. First of all, we want to agree with the uncertainty of the fear. We want to kind of trick the amygdala by showing it that we don't really have an emotional response to whatever that fear is. So we're going to be like, I talk about kind of using a whatever teenage attitude. Parents love that, but anyway. And by doing that, we're going to acknowledge and externalize OCD, right? We're going to acknowledge that it's there, but we don't want to talk back. Once we start to talk back, we're giving importance to the thought, and we don't want to give that importance. By doing the not talking back, allowing the thoughts to be there, what's happening is your patient will start to experience habituation to those thoughts. And instead of suppressing them, they're going to accept them and the feelings that come from them. And then finally, we can also use positive self-statements or coping strategies, coping statements to just help tolerate ERP and motivate them to do it and tolerate the anxiety that comes with it. So with younger kids, what to say to that OCD bully? Well, hi OCD, I guess you're hanging out with me today. Sure OCD, whatever you say. You don't have superpowers. You don't know what will happen in the future. Maybe I will hurt myself, maybe I won't. I don't have to do what you say. You are not the boss of me. Hey OCD, you can hang out with me. I don't care. I'm just going to keep reading this book. So I want to just show you this was something that we wrote up with a little boy that I was seeing, and he was 12 or 13, and his OCD was called WR, and WR was going to say, oh, you're going to choke. And so what WR would be like, oh, you're going to choke. And what would he say back? He'd be like, hey, WR, what's up? Oh, there you are. I've been looking for you. Again, lack of emotional importance to it. Welcome back, WR. Hey, you're going to hang out with me? Okay. I want to feel scare anxious. It's a chance for me to give you a taste of your own medicine. I am not going to do what you want me to. It is time for a change. And these are some of those coping strategies to help him realize that anxiety is not bad, and that when you feel anxious, you're fighting back OCD. Okay, so I've talked a little bit around the first three parts of getting ready for treatment, and now I'm going to talk about kind of putting together that toolbox and identifying the fear, and then we have our second part in the next webinar. So the behavioral part of CBT is exposure and response prevention therapy. Exposure is exposing your patient to the triggering situation, place, object, thought, or even feeling. And you can do exposure in two ways, by flooding or gradual desensitization. Response prevention is where you are basically encouraging your patient to refrain from doing the ritual. We're not forcing them not to do it, but we're encouraging them. And when we look at what's happening during exposure and response prevention, this is a great graph that kind of shows what's happening to anxiety over time. And as you can kind of see here, you're going to expose the person to the trigger. They're going to stay in contact with it. They're going to feel that anxiety. And then over time, that anxiety is going to subside. And this process is called habituation. And for the amygdala to learn to stop sending that false alarm, it needs two types of habituation. It needs something that we call within trial, which is, as you can see, within each trial, the anxiety is going down, right? 4, 3, 2, 1. It also needs something called between trial habituation, which is showing that between each trial, we're seeing that the anxiety is lower. And so what that means is the repetition of trials is an important aspect of ERP. So this idea of habituation is getting used to. So I will often use this analogy with younger ones. I talk about kind of, it's like riding a scary roller coaster. And I will often tell a story about my daughter when she was young and how she was scared of this roller coaster, but we did it many times over and over. And eventually what happened is by the end of the trip, it was her favorite ride. So the more we do it, the easier it becomes. So what your patient is learning when they're engaging in ERP is that over time, if I don't engage in that compulsion, that anxiety is going to subside on its own. They learn that they're able to tolerate the anxiety better than they thought they could, and that their feared consequence does not necessarily happen. So when we're training the amygdala, we can't talk the amygdala out of its fear. It's in that feeling part of the brain, so it needs to feel that it's not anxious. And by having your patient act as if the situation is not dangerous, by staying in contact with the trigger and not doing the ritual, then the amygdala eventually learns and it feels the anxiety subside and habituation occurs. And then once it learns that it's not dangerous, then it stops sending that false alarm. We always have this tendency when we're afraid of things that we want to kind of go around them. But when it comes to OCD, the only way that you're going to be able to kind of get over or get through that is you have to allow your patients to go through their fear. And the reason we can do this is because this is a maybe danger, not a real danger. So I want to talk a little bit about assembling the toolkit, because before we start ERP, we actually need a set of tools. And again, I use lots of analogies, as I mentioned earlier, but skiing or snowboarding, would you go to the top of the mountain and just come on down if you've never taken a lesson? No. You need to learn how to stop. You need to learn how to turn. You need to learn pizza and French fries and how to ride on a lift. Same thing with ERP. We need some tools. So the tools that we need are a journal, anxiety scale, and a fear hierarchy. So the journal is really an opportunity for you as the therapist to really do a thorough functional assessment. And what you want to do is you want to ask lots and lots and lots of questions. They must think I'm so nosy because I'm always asking questions. But we want to kind of get a sense of where and how is OCD interfering in their life. And what I'll get them to do is have a journal. And with young kids, again, get a new little journal, make it fun. Often I'll talk about them being a detective and how we have to, get clues and get evidence and find out how OCD likes to boss you around. With older teens, I'm talking about kind of a life in the day of. And I'll get them to kind of explain a school day, from the time you wake up in the morning to the time you go to bed at night. What did OCD get you to do? Do it on a school day, do it on a weekend day. And then it's super important that you also gather information of how the parent might be involved in OCD. Are there behaviors the parents are doing? Are they tangled up in the rituals? Are they actually doing the rituals for the child? And then finally, we want to look at any behaviors or objects or situations that the child or teen is avoiding, because often the things we avoid are triggers. So we want to gather all this information. And then with young children, what I like to do, because I talked about kind of concrete objects, is I like to kind of map it. And again, we'll draw a little map, and by taking all that information, we can break it down into where does OCD bother them. So, here we got playing outside, at a friend's house, sports fields, and the bathroom. And have a legend with 3 different colors, each one representing, the first one color would represent where OCD is in charge or OCD is winning. The next one might be where the child is winning. And the third color is going to be where both are winning. And what we can get from this, and what it helps the patients and the parents notice, is that, hey, you know what? OCD is not winning everywhere. There's actually places where you're in charge. And it also helps us look at, okay, where are both of them winning? Because that's where you're going to kind of start the treatment. We're not going to start where the child's winning because we don't need to. And we're not going to start where OCD is winning because that's going to be too hard. So we're going to look at where are both of them winning. And that's going to be where we're going to kind of start the process. Another tool that we need is an anxiety scale. And this really is a scale that is going to be used to rate how much anxiety the child or youth is experiencing when they're triggered by OCD. And it is going to be used as a communication tool that I will use with them. I'll use it during ERP. I'll use it in general. It's something that I want the parents to be using because it helps them know how to respond to their child depending on how anxious the child is feeling. So the question is kind of how much is OCD bothering you? So with young children, I often look at kind of creating a fear thermometer. And one of the things I like to do, especially with the little ones, is actually we make one in the session. And you can kind of see they have some fun being able to kind of put it up and down. And that's kind of something fun for them to do. And they also like to be able to use that at home. Now, with still kids, but a little bit older, I might just have, this is a great fear thermometer picture from Anxiety Canada that uses emojis to sort of show the emotions rather than having to use numbers or have explanations. And then with teens, I'm going to be having kind of this fear scale where each number we kind of explaining what it represents. Once we have both of those, we're going to use the information that's gathered and we're going to start to create a fear hierarchy. Now, before we can create a fear hierarchy, we need to know what the fear is and the feared consequence, which is kind of that core fear. So helping through lots and lots of questions, we need to help the youth identify what is the fear. So the journal, we're going to go through the journal, identify triggers that they had throughout the day, and then I'm going to ask them more of those nosy questions. You know, what were you afraid of? Well, that my sister would get COVID. Well, if that's true, what's so bad about that? Well, she will die. What's the fear? Well, that someone's going to come in my house at night. And what's so bad about that? What does that say about you or others? Well, mom and I could get molested or assaulted. And so by asking these questions, we're really trying to get at what that fear is and that feared consequence. Now, with younger children, they are not going to necessarily be able to just identify that. So I will use what I call thought bubbles, where either I will draw, which you can see I'm not very good at, but I might draw a picture and get them to kind of write in what that fear is, or I might get them to draw a picture where they can write what their OCD bully is saying to them. So then once we have the information gathered and have identified the fear and feared consequence, we're going to develop a list of situations, objects, places that are avoided or that bring on that fear. We're going to rank them using the fear scale or thermometer, and then arrange them from the easiest to the hardest. Now, items that are less provoking, anxiety provoking, will be at the bottom, and the most are kind of at the top. And then if there's more than one fear, which there often is more than one flavor of OCD, we will have more than one hierarchy. So when I'm working with kids, I like to have a bravery ladder where they are, and here I'll just show you some samples. I'm not going to go through these in depth, but there you can sort of see that the lower items are rated at the bottom. So sending a text message and do not check it. Then up at the top, we have lock the door and do not check to make sure it's locked. Here's another one for repeating. And so with younger children, I'll be using kind of these bravery ladders. And I'm going to show you what I would do with older kids right now. I'm going to talk a little bit about, there was a 13-year-old girl, and she had a fear that she was having thoughts that she might harm the people she cares about. And as her compulsion, she had to do like some superstitious type rituals. So she had specific routines she had to do to make sure she wouldn't act on these thoughts. She had to confess when she had these thoughts. She would avoid things that made her afraid. And so we used her journal information and we developed kind of our fear hierarchy from that. And here's a great table that John Piacentini used to help people understand how to develop a case formulation. And so what you want to do is you want to kind of take your formulation statement. So if I'm exposed to this trigger, a sharp object or image or thoughts or information related to harm, I need to do one of these actions to neutralize the anxiety and threat: avoidance, reassurance, confess, or else this might happen. I might act on these thoughts, and then these catastrophic outcomes will occur. Well, I might hurt someone I care about, and it means I'm a bad person. So we can take that information, and we created a fear hierarchy. So you can see here at the bottom of the fear hierarchy are things that she rated kind of 3s and 4s. And those were things like changing part of that bedtime routine. Then we got up to sort of looking at sort of not texting with mom while she's at school to make sure mom was okay, cutting vegetables with mom being present. And kind of at the top were things like kissing mom on the wrong cheek before she left the house. Again, one of her routines she had to do, and not confess. Now you can see here in red that I have highlighted kind of hold a knife. And the reason for that is because we wanted to go after that in more depth. And so we created what I call a mini fear hierarchy that went after the not holding a knife. So we would start with sort of pictures of like animated knives. Then we moved up to pictures of sharper knives, then looking at a real knife, different distances, and then holding a knife while listening to something that talks about her fear, then holding the knife in that stab position, and then even kind of that stabbing motion with the knife. And believe it or not, we actually got to the point where we had her kind of stabbing a picture of her mom, and while holding that. And I can't see faces, but I might see some shock if I did. And the reason for that is because when we have to go after what OCD really is saying, we have to go after those 10s, and we have to fight fire with fire by going after what OCD is saying. And that's what it was saying. And it goes back to, real quick, it goes back to that idea that just because we say or do something doesn't mean that it's going to happen. Now, obviously, we're not going to use that in the moment, but that's kind of that education that's in the back of their head. Okay, I'm going to give you another example. This was a 17-year-old boy, and he had a fear that he might accidentally become contaminated with semen or an STI, and that he would either infect other people or accidentally impregnate a female. And so his compulsions were that he would avoid sitting directly down on chairs and sofas, both at home and school. He'd always kind of put something down first. And when he came in my office, he would always put like his jacket down. He wouldn't sit on the chairs there. He avoided places like pools that he thought could spread semen or STI viruses. He did a lot of internet searching, and he was excessively checking himself to make sure that there was no semen leaking or that he had an STI. And so again, here's some examples from his fear hierarchy. So again, you can see at the bottom, we have things like, looking at pictures of sperm, and it can be animated pictures, it can be real pictures. Sitting on a chair at school with his shorts on and nothing else underneath. And then a little bit higher, we get up to, putting liquid down his pants without checking. So feeling the uncomfortableness of feeling wet, but not being able to check. Kissing his girlfriend after he went swimming. And finally, at the very top are things like reading about teenage pregnancy and sitting in a sauna. And I think I'm going to show you, I have one more example that I wanted to show you. So this was a 14-year-old girl, and she had a fear that she was going to act immorally, cursing, not telling the truth. And she actually had a fear that she was going to going to become like a drunk, and to her, these were considered immoral at that point. Her compulsions were that she would avoid images and situations of drinking and smoking and vaping. She would mentally review what she said in her head to make sure that she did not lie. So she mentally reviewed the conversation she had. She would confess if she had an immoral thought. She was confessing to her mom and dad all the time. And there was excessive apologizing happening. So here's some examples from her fear hierarchy. So we had pictures of cigarettes and vapes, and she had to look at those, and alcohol. Coming up a little higher in her hierarchy, you see sort of looking at, having real alcohol in front of her and a cigarette and a vape, telling an incorrect fact or a white lie. And then I had her kind of at home, she had to sort of play games and cheat. Going on an Instagram site that she considered immoral, so showing people partying or drinking. And then finally at the very top was kind of watching movies around partying and cursing and teenage sex. Now, one point I do want to make here is that obviously we want to incorporate parents into some of these situations. And so this is one of the reasons we incorporate parents in treatment, is they need to understand, why am I getting their teen watching these movies or something? And the reason is because we have to kind of go after OCD. So you're going to want to get permission in these scenarios to make sure that the parents are on board as well. I've never had a parent not be on board. Often one of the things I'll do is I'll have the parent kind of find the information. And this is more for younger kids. So I'll have them kind of find the information or the picture and make sure they're okay with it before the child is exposed to it. So that just kind of gives them that sense of knowing what it's going to be for the parent. Okay, so I believe I'm getting to the end here. So I wanted to just talk about kind of the take-home message here. I guess the first thing is, when we're starting ERP, that it's super important that we're going to be using age-appropriate language, using metaphors that the child or the teen can relate to, but you also want to make sure that you're very direct and that you're direct in what the treatment is and what it's going to look like, and that you're able to kind of help the parents and the youth sort of buy into that treatment process by using this and using that psychoeducation, because it's super important. This is not easy. The treatment's not easy. It's very uncomfortable. And so we really need to get them to buy into the treatment process, motivate them with incentives. Identifying the fear and the feared consequence, sort of that core fear, and going after it is super important. We don't want to just scratch the surface. We really need to know, what is it, that core fear that OCD is scaring them about? And we want to help them accept uncertainty and doubt, and take risks. We take risks all the time in our lives. And so, every time we walk outside, we could get hit by a car. Every time we get in a car, we could get in an accident. So we're taking risks all the time. And so it's no different when it comes to OCD. We need to take risks. You want to create individual fear hierarchies that are related to a specific fear. And again, if there's more than one fear, you're going to have more than one hierarchy. You want to ensure that the ERP steps in the hierarchy are not too large. And so you might need to use mini hierarchies. And also you want to ensure that if there's something you really want to go more in depth with, then you're going to use those mini hierarchies as well. And finally, you want to ensure that you teach how to talk back to OCD as a bully and accept the obsessions as possibly true. So we're not challenging the reality of the fears or pushing them away, but allowing them to kind of accept them. And really quickly, when I say accept them, I want you to understand that I have my patients understand that, there's a difference between what we know in here and what we do up here to fight back the OCD bully. In here, we know that we're not going to hurt anybody. But up here, we have to agree with the possibility, because that's the tool we need to teach that amygdala. Okay, so I think that's the end of my session. Yeah. And so what we're going to do in the next session is I will look at implementing ERP and some case examples around that. Okay, excellent. Thank you very much.
Thank you, Dr. Sapp. That was truly excellent. Thank you. So I see there is a question in chat, and we have around about 7 minutes or so for Dr. Sapp to answer questions. In the meantime, while that's ongoing, I will launch the next poll, which is the post-webinar evaluation. And while the Dr. Sapp is responding to questions.
Yeah, I'm looking over here. You can see me just looking over. I'll respond to a couple of sessions.
Okay.
Or a couple of questions, sorry. Okay, well, I see one question. which is, when would you move on to the next sphere in the hierarchy? In prolonged exposure for PTSD, we wait until the SUDS level is down to 3 out of 10 or less. Also for homework, how often would you get them to do one of the items? Oh, good questions, really good questions. Okay. So when we're starting with the fear hierarchy, I like to start with them where they're about a 3 or a 4. And for me, that means like a 3 is where they're just uncomfortable. At a 4, they're anxious and maybe they can fight back OCD. So I'm going to kind of start there. And I typically, when I'm first starting with them, I really want that brain to get retrained. And so we're going to bring that all the way down to that 0. We want to kind of bring it all the way down to a 0 before we move on to the next trigger, so that we really retrain the amygdala. And as we get more into the treatment and people are more used to doing ERP, I'm not going to get them to necessarily get all the way down to a 0, but I might say, you know, when you're like a 1.5 or a 2, let's try and make it harder. And the reality is, even if they're not at that and they start, you know, they go from one session, they come to me the next week or the next 2 weeks, I'm going to push them a little bit harder. So I'm always kind of pushing them forward when I'm doing ERP with them as they come through this each session. And also for homework, well, I actually, I make them do homework every day. Well, I ask them to, I don't make them obviously, but that's where, again, that incentive comes in. I'm wanting them to get rewarded for doing this homework because, and you'll see in my next webinar, I'll talk a lot more about how exactly ERP is implemented, but basically we know that, you know, doing up to 60, even up to 90 minutes of ERP a day, and obviously I'm not going to get, you know, kids doing 90 minutes, but we do see that the more they're doing the more they're doing between session ERP, the better we see is more, the compliance of that predicts outcome of treatment more than just within session. So I'm going to try to get them to do it each time. How do you work? Okay, here's another question. Oh, I hope that answered the questions. Now I'm going to ask, there's another question down here, which is, can you talk about how to work with guilt in youth with OCD? Okay, well, as I mentioned earlier, doubt and guilt are the biggest components that OCD uses against the patient. And so that's a big piece of the education, helping them understand that the guilt piece is OCD. It's what OCD is using against them. And again, it goes back into that piece of the educational part where we're looking at the assumptions and kind of what I alluded at the end, which is that even though we know in here we would never hurt, you know, I'm not going to stab my mom, but I have to still respond as if I will, or act or do the ERP, which is very guilt provoking, but helping them understand that that is OCD and it's not them, and that we know the difference here. And the only reason we're doing this is because this is a tool that we need and what we have to do to retrain the amygdala. And so it helps them kind of, that takes away the guilt. And plus we're externalizing all of this. So I am taking that guilt away by helping them see OCD as the one who's causing that and the one who is, you know, bringing on that guilt. So it helps take away that. Another question here, how would you go about ERP with a patient who is struggling with OCD, like hand washing germs, but is also low functioning and has schizophrenia? Ooh, unable to create a fear hierarchy. Oh, that's a very good question. Let's see. I haven't had that scenario, but I think the most important piece is we're going to have to kind of see what they're able to do. When someone is low functioning in terms of their cognitive ability, then I'm really focusing on the behavioral changes. So it will be more of finding, like, for example, if they have fear around hand washing and germs, we might create a list of items that trigger them, and in session have them test it out so that we're trying it out. So I would do a lot more of in session and showing them how to do that. I don't know if, I hope that answered your question.
We have about 2 minutes left, Dr. Sapp, of questions.
Yeah, I'll answer this very last question. Do you have a recommendation for youth struggling with that just so feeling, repeating, fixing? It has been difficult to identify. Okay, a clear fear or feared consequence. Well, that is the feared, the fear is that if I don't do this, if I don't repeat or fix it, this icky feeling that I have, it's not going to go away. I'm not going to feel right. So they have to not do the behavior and then sit with that uncomfortableness that comes from it, as well as the fear that it's not going to go away. Okay, I think that answers most of the questions, which is great.